Good afternoon and thanks for joining our GP20 on-demand session titled Navigating the Latest Options and Updates on CVD Prevention. My name is Natalie Ruffell. I'm a clinical pharmacist by background and I'm the Cardiovascular Disease Risk Reduction Manager at the Heart Foundation. The Heart Foundation is very excited to be collaborating with the RACGP Cardiology Specific Interest Group to bring this session to you today. And we're really looking forward to providing the latest updates on the evidence and policy changes on CVD prevention. I'll be one of your co-facilitators today, and before I pass on to my other facilitator, Dr. Atif Hashim, I will like to formally acknowledge the traditional owners and custodians throughout the country in Australia and their continuing connection to land, waters and community. We pay our respects to them and their cultures and elders past, present and future. I'll now pass on to Atif to give you a bit of an insight into our session today.
Okay, thanks, Natalie. Firstly, I would like to thank the National Heart Foundation and staff behind the scene for the great work over the last few weeks collaboratively with the RACGP Specific Interest, and I hope that it is a start of a blossoming relationship with the college. For those who are not aware, the RACGP Specific Interest Cardiology is a growing group of almost 1,500 now of GPs with a special interest in cardiology, including GP trainees and registrar and fellows. Established mid-2017, we hope to get more GPs who have specific skills or interest in cardiology to join us. This year, the GP20 conference has a different feel to it. Things are finally looking up with Victoria joining the rest of the country and the beginning of to open up industry. Today, as you have heard from Natalie, for the next half an hour, we will be talking about cardiovascular risk assessment and how it is relative to general practice. We will conclude with a Q&A. It is important to know that more than 2/3 of Australian adults are living with at least 3 cardiovascular risk factors. Data suggests that uptake of cardiovascular risk assessment may be suboptimal. About less than 7% of eligible patients had their cardiovascular risk recorded via inbuilt calculator, and only 17% had all the relevant risk factors, including blood pressure, cholesterol, HbA1c, and smoking status. Today's interactive case-based session will provide the latest evidence on strategies that support cardiovascular risk assessment and management, including an update of new guidelines and policy changes. By the end of this presentation, we would hope our listeners would be able to acknowledge the evidence and apply strategies that support systematic assessment and management of CVD risk at a practice level, and importantly, explain the new heart health check MBS item, which you're going to hear about it soon, and how it can be leveraged to improve patient outcomes and describe new and engaging ways to communicate cardiovascular risk and empower patients who participate in shared decision-making. We actually are lucky to have speaking to us Professor Mark Nelson. Mark is a professor and chair discipline of general practice, School of Medicine, and senior member of Menzies Institute for Medical Research, where he's also a medical director of the blood pressure clinic, both at the University of Tasmania. He is also an adjunct professor, Department of Epidemiology and Preventive Medicine, Monash University. His research interest focused on large-scale clinical trials in primary care, and he's a principal investigator on the ASPRE and STARI trials. He also works in clinical general practice in Hobart. So please join me in welcoming Professor Mark Nelson. Over to you, Mark.
Thank you, Atif. If I can just share the screen. So, first up, thank you, Atif, and thanks to the Heart Foundation for the opportunity to spruik about the benefits of taking an absolute risk approach to the prevention of cardiovascular disease in Australian general practice. Heart Foundation's been a great supporter of this over the years. Firstly, I have no relevant conflict of interest to declare. When most of you were trained as doctors, you were especially taught about the concept of hypertension. Above a certain blood pressure level, you had a disease called hypertension, and below that level, you were normotensive. Originally, this was about 180 millimeters of mercury, but over the years, this has gradually come down to 140 millimeters of mercury, and the United States guidelines have gone down to 130 millimeters of mercury for high-risk individuals. So that's the way we're used as doctors to talking about blood pressure and cholesterol. As disease processes above a certain level, we have this disease, and below we don't. And we're really ignoring why we manage these factors, because they're not really the disease entity in itself. What we're trying to do by controlling blood pressure and lipid levels in our patients is to prevent heart attacks and strokes. The major adverse cardiovascular events that are associated with these risk factors, but also approximately another 254 independent risk factors for cardiovascular disease. So the emphasis is now shifting away from looking at individual risk factors as disease entities towards treating them more holistically, which should fit with the way we think about our patients as GPs, holistically, not just the patient who has hypertension, but the person who has raised blood pressure, who smokes, who has diabetes, and who spends more time at the 19th hole than actually on the course at the golf course. So this shift of this strategy is more efficient from a public health perspective as well. It makes sure that those who get medical treatment are those who are more likely to benefit from it. And also it helps avoid giving disease diagnosis to people who are very unlikely to have a heart attack and stroke, and therefore who suffer the adverse effects of over-treatment and carrying a sickness that may have implications for their mental health, employment, etc. So we all know the prevention paradox is that even though the person, if you look at individuals, the individual who's more likely to have a heart attack or stroke is the person who has already had a heart attack or stroke. We know that actually the vast majority of the people who will have an event, it will be their first event. So that if you want to prevent the majority of heart attacks, you've actually got to look at the primary prevention population. So the absolute risk approach is the most effective approach, as I spoke to before. If you look at this Venn diagram, I think it really does illustrate that. If you look at high blood pressure in isolation and you define it as hypertension, then you're going to get a 1.5 increase in risk of having an event. Cholesterol on its own, 2.3, diabetes, 1.8, and there is interaction between them. But if you see the person who has all of these together, then you see that the multiplication of risk is far greater. So it's not just additive, it's multiplicative. The thing is that once you get down to adding up 3 or 4 or 5 or 6 different variables, then it's very difficult for you to do that on your own. Is that it's very easy to estimate the relative risk. That's the risk of somebody having a heart attack or stroke relative to somebody of their own age or gender. But if you think about it, 60% of your risk of having a heart attack or stroke is related to age and gender. They are the most important determinant of risk, and all the other variables explain the rest of the 40%. So to bring those together into a reliable estimate of who amongst your primary prevention patient is likely to have a heart attack or stroke in the next 5 years, and that is the definition of absolute risk, you need to do a formal calculation. Not even somebody such as myself can reliably do a calculation in my head. So you want to do all of these. You want to think of your patient as holistically, and you want to do it in an absolute risk approach. So we do know that CVD is largely preventable. If you said it was immutable, then how do we explain the fact that the event rate now is about a quarter to a fifth of what it was in the early 1960s? So it is largely preventable, and we can say that the big contribution to that has been public health measures around smoking cessation, etc. So modifiable risk accounts for approximately 90% of the risk. This is the preventable risk. So it is worth identifying these individuals to address their risk factors. They're well defined. I mean, you can easily measure these in your clinic by simply taking a blood pressure or ordering a pathology test in the main to contribute to your cardiovascular risk calculation. It is more effective, as I spoke to you before, is that if you take a single risk factor approach versus the more efficient one, you're far more likely to prevent far more events than you are if you just manage on CVD alone. And I can give some illustration of that later. Targeting therapy to high-risk groups creates a greatest benefit. It is that if you do any clinical trials, and I do a lot of clinical trials, is that what you notice with therapeutics, they have a pretty stable relative risk reduction. And what drives whether anyone's going to benefit or is likely to have an event in a study is their absolute risk. So if you have a 20% reduction in somebody at 20% of risk, then your absolute risk reduction is about 4%. But if it's in somebody at only a 3% relative risk, then it's going to be less than 1%. So you can see that you're far more likely to benefit individuals if you base it on the absolute risk alone. And CVD risk calculators are essential. I made that point earlier, is that you can't rely on your intuition or your knowledge of the patient, or that in my own practice, I have had surprises. I had an individual who had fantastic blood pressure and lipids. He was a early 60s male. The only driving factor he had was a HDL-C of less than 0.7, and that was driving, and I put it into a calculator, and surprise, surprise, he was a high-risk individual. And with a lot of convincing, I put him onto a combination calcium channel blocker and a statin, and 7 years later, he presented for his triple bypass. He hadn't had an event, he just had gradual onset. So certainly he would have had subclinical disease, which I wouldn't have identified by individual risk factors. So how do we do it? Some of you are probably familiar with it. It's on your, it's usually an icon in your clinical software. Who do you do it on? People aged 45 to 74 years. From 35 years in Aboriginal Torres Strait Islander peoples, and that was based on the 2012. Since then, I will be mentioning this later, but since then there have been recommendations from an expert committee, a guideline that recommends that be taken down to 30 years, so 30 years for Aboriginal Torres Strait Islander peoples. So you can do that simple with measures that are often already exist within your practice. You'll know their age and gender. Smoking status is very well recorded in general practice. So is blood pressure and cholesterol, diabetes. So all of those are well recorded, and all we need to do is pop them into the calculator. And that's often automatically populated. So it's a very simple thing to do. The left ventricular hypertrophy is an optional entry you can make into the calculator. It was added as a measure of target organ damage. One of the things that might help you reclassify somebody who you're wondering about, should I treat them or not? Family history and ethnicity, and I always get asked this question about family history and ethnicity. Why aren't they in the calculator? If you look at the drivers around the world in different ethnic groups, is that they are the same factors and in the same relative importance. So, but ethnicity can increase your background risk. And so somebody who comes from a high-risk group, such as Aboriginal and Torres Strait Islander people we've spoken about here, or South Asians, under those circumstances, if you calculate their risk as being moderate risk, the 10 to 15% band here, then you can reclassify them because of that ethnicity or family history or gross obesity or additional risk factor that you are concerned about and you consider may cause the calculator to underestimate the risk in your individual patient. So you calculate the risk. As I said, that is available on clinical software. If not, you can download it from this website, cvdcheck.org.au, and then manage the risk accordingly. The common complaint that we have under these circumstances is you might have somebody with normal tension and normal cholesterol levels. In reality, the level, it's arbitrary where you start treatment. If you get a 20 millimeter reduction in blood pressure, you get the same benefit from going from 160 to 140 as you get from going from 140 to 120. So, you know, concern about why would I treat somebody with a blood pressure of 138 millimeters of mercury? The answer is, well, because their risk is elevated and they would benefit from having their blood pressure lowered. The mainstay of treatment is always lifestyle. So another complaint I have about the use of absolute risk score is that it is heavily determined. I mentioned that the vast majority of risk is determined by age and gender. Therefore, if you're at young age, you can have high individual risk factors, but low absolute risk. So you can end up in the green session. But that doesn't mean no treatment, the fact that you aren't recommended to give drug therapy under those circumstances. It will be an indication if at a young age they have already adverse risk profiles. It indicates that there will be a lot of behavioural aspects and lifestyle aspects that you can intervene in. They're likely to be smokers. They're likely to have their blood pressure driven by high alcohol intake, sedentary lifestyle, etc. So the recommendation is that lifestyle is recommended first-line treatment for all low, moderate and high-risk individuals. That medicines are mandated in people who are at high risk, which is over 15%, which is, if you think about it, a 1 in 6 or 1 in 7 chance, like a roll of the dice of having a heart attack or stroke over the next 5 years. So we'd recommend that they take blood pressure and cholesterol-lowering medication, irrespective of their individual risk factors. And for people in the intermediate zone of 10 to 15%, then you could consider reclassification either with those additional risk factors that I mentioned earlier, family history, morbid obesity, coming from a high-risk ethnic group, or other aspects like calcium channel scoring, etc. So we've come a long way. So the first guideline was published in 2009 by the National Vascular Diseases Prevention Alliance, which is an alliance of Kidney Health Australia, Stroke Association, National Heart Foundation and Diabetes Australia. And they started this process because they all realised that the common fatal pathway for all of their patients, whether they have kidney disease, whether they've got diabetes, was that they would have an adverse cardiovascular event. They would have a stroke or a heart attack. So the definitive guideline actually came out in 2012, and there was a lot of post-guideline education, implementation programs. The National Prescribing Service was particularly good at this, as was the Heart Foundation. The adoption of these guidelines, you might remember originally Medical Director did have a risk calculator built into it, but it was a relative risk calculator, not an absolute risk calculator. So eventually they've all adopted an absolute risk calculation. And probably one of the big breakthroughs we had was to get rid of the 9 criteria that were utilised for access to statins, and it's now freely prescribable from 2017. You don't have to meet the sort of bizarre individual criteria required by that prior to that date. 2019 Quality Improvement Practice Incentive Program and the new MBS item number, which I know there's been some resistance to the uptake, but is really worth doing because it has a one of the formal processes is to do an absolute risk score within it. Okay, we know that Atef said in his introduction is that we've got a long way to come, is that a lot of people who are at high risk aren't getting the treatment that they require, and that is because we still take the approach of individual risk factors, disease approach, rather than taking an absolute holistic approach. So you can see here that over 70% of high-risk patients are missing out on blood pressure and lipid-lowering measurement. So they may have elevated blood pressure, so they get the blood pressure, which will reduce their risk by 15 or 20%, but they could get another 20% if they had their reduction, if they took a statin as well. Well, we can see that in figure 2, that there's 43% of high-risk CV patients are not prescribed a statin. Right, so it's an illustration of that this actually does happen in real practice. I'll give you a couple of patients that I dealt with myself. So in the practice, because I'm sort of known for this as a guru of CVD prevention, is that if somebody has an event, they're sent along to me afterwards. So I do a critical event audit on any of the other patients in the practice or myself who has an event. And I look at the 2 years prior to the event to see if we could have improved management. And one of the things that I do is to do an absolute risk score if they haven't been on treatment prior to it. I mean, obviously, if they've got known heart disease, or if they've had a stroke in the past, or if they're on dual therapy anyhow, there's no sense in doing it because they're already on treatment. But if they don't have any treatment, I go back. So these are just the 2 last ones that I saw. So a 61-year-old smoker who didn't have a blood pressure over 140, and he had cholesterol, I think it was about total cholesterol of about 5.3, taking no medication. He came to saw me post his inferior myocardial infarction. I put all of his individual risk factors prior to the event into the risk calculator, and he showed up as being an absolute risk score of 17%. So if somebody had done an absolute risk score in the period prior to it, he would have had perhaps anywhere between a 40 and 90% reduction in his risk of having that myocardial infarction. Similarly, I saw soon after that a 73-year-old male who was a non-smoker, again, no elevated blood pressure or cholesterol. And in the 73-year-old, you're starting to think, well, if he hasn't had it by now, he won't have one. And he had a thromboembolic stroke. It wasn't related to atrial fibrillation. And again, put him into the absolute risk score, and an absolute risk score of 17%, a lot higher because of his age, as you could imagine. Again, if he'd done it, I mean, we know that the reduction in lipids is less a driver in stroke, but certainly a reduction in his blood pressure would have helped with his stroke reduction. So I would encourage you to do this on your own patients as an exercise. In fact, the Heart Foundation did do a process of promoting about the unexpected death or heart attack, usually in the middle-aged male. And if you go back and do a clinical audit of those patients, you'll probably find that they were an unrecognised high-risk individual. So what's happening at the moment? So the Australian, to do it, you need to know age and gender, which is automatically populated in your clinical record. You just need to know the blood pressure, smoking status, total cholesterol and HDL-C, because it's the ratio you're interested in, and whether or not they have diabetes. The other things can be considerations that you have to make. So Medicine Insight, I don't know if you've been involved with it, but it downloads automatically computer records of de-identified individuals so that they can look at practices around the country in vast numbers. So they did a random sample of 25% of patients aged over 18. So anyone over 18 is eligible to have their blood pressure. And they then looked at those who were aged 45 and above. See, that is the minimum age to do it in the general population. And they had 351,000 who were eligible for the new heart health check. And as I mentioned before, they had 67, the recording of blood pressure, smoking status, less so cholesterol, but not too bad. 21% having a glycated hemoglobin, with that would reflect the population prevalence of diabetes. So the fact that it's so much lower is not a concern to me. But only 17% of all eligibles had all four of the necessary to do a calculation. So you can't do that without a calculation. Okay, and 6.7 had formally used the calculator in the software. And as you can see here, brought up on the right side of the screen, it's automatically populated. So if you've done a total cholesterol or HDL, that will automatically go in there. And if you recorded a blood pressure in the drop-down menu, that will go there. And it gives you a little bar here to illustrate this. And of course, these numbers, these colours are chosen as part of the communication, in that green is low risk, yellow is intermediate risk or moderate risk. So that's the warning area, and red is high risk, and that's take action. All right, so we know that we have these CVD health checks, and we know who comes in to see us: older, female, married, lives in affluent areas. And of course, it's a little bit of an inverse care law, because just like the reason why chronic disease management plans often fail to be shown in studies to show benefit is that often the people who will attend in normal practice to have them done are the good attenders who are well managed and who are likely to be to take their medications and follow lifestyle changes. So again, we're seeing here the one thing that does stand out is older, and that's important because the elders are at risk of having a heart attack or stroke, although the middle-aged individuals are the ones who are going to lose more years of life if they don't have the event. So we probably need to look at more systematic ways of doing this rather than ad hoc, because people will attend in an inverse care relationship. So who are less likely to attend? Okay, smokers, males, low SES, and have more risk factors. So we're seeing the inverse care demonstrated by the lack of attendance and the people who will most likely need the intervention. Right, so personal relevance of CVD is a key driver. So we've seen this in clinical practice. You know, if my brother has a heart attack, then I'm more likely to attend. people that understand the preventable nature. So if somebody understands that smoking is bad for my health and it's likely to give me a heart attack, and therefore come along and seek advice about how they can stop it. So it is a matter of health literacy, social support. So we mentioned before that people who are unlikely to attend are those low SES with lower socio support, etc. Access, lack of equitable and easy access to the hard health check is a barrier. And the other important thing I think that we can take from this is that we need to be more proactive. If we're going to do things in a systematic way, rather than rely on our patients to attend, is to send them out letters of invitation to run screening programs and integrate absolute risk scores as part of the things we do for the patients, just as we do now with blood pressure. So I would say that blood pressure is important, but the number they need to know is not their blood pressure, but their absolute risk. So I think you're all probably quite familiar with items 699 and 177. The item claim depends on whether you're vocationally registered or not. And the eligibility is the same around that of the absolute risk guidelines, except you'll notice that because this came out later, that it's now got the 30 years rather than the 35 for people of Aboriginal and Torres Strait Islander backwards background. Duration, there is a time limit, so it's beyond a level B consultation in a standard thing, but we need to collect all of these. But you may be able to look at historic samples, so you don't have to repeat your patients. For example, if your cholesterol has been done in the last 12 months, that changes very slowly and is likely to be representative of what their blood pressure is on this attendance. So at the end of all of this, and remember, just like chronic disease management plans, is that the nurse can contribute to the time to do this. It's essential that you do an absolute risk score. This meets with the preventive health assessment guidelines, recommendations. I think this is taken from the Red Book. I may be wrong. And we always have a great support in our practices from our practice nurses. I'm sure we're all working as a team. We recognise how much more efficient they make a day as a doctor due to their professionalism, and many of the things they can do superior to us, for example, taking a blood pressure. They can eliminate the white coat effect, and they're far more likely to take it with a standard approach than us doctors. We tend to cut courses. So I mentioned before about systematising the approach so practice nurses can perform record searches and active recalls. You're probably already doing that for things like vaccinations. You can collect the CVD risk factor that is already in the medical record and identify deficiencies. And then you can complete the risk assessment and recommendations. What I do say, we always complain about how difficult it is to change the behaviour of our patients. I always say it's even more difficult to change the behaviour of doctors. And the important thing, if you do take up the absolute risk approach, which I say you should, is that when you do identify a patient who is high risk, that you actually do follow the recommendations and provide them with therapeutics, as well as the behavioural and lifestyle changes that they'll need. The nurses can reinforce the lifestyle advice and management plans so that they can have something formal to leave, that is written and formal to leave, and then they can be assessed over an extended period. If you're prescribing, obviously you'll need to at least see them 6 monthly. And follow-up and monitoring, but the Rubicon of crossing is to identify those high risks and to commence them on blood pressure and lipid lowering therapy. All right, I think we've probably completed this. So the Heart Foundation has done estimates that if we take this approach, if we formalize it, systemize it, and get to those hard to reach individuals, that we could prevent more than 75,000 heart attacks, strokes, and deaths over the next 5 years, which is a considerable amount. I can say it's long overdue for the 2012 guidelines to be updated, and that process has just begun. So hopefully we'll have more contemporaneous data and algorithms available at the end of that process. I also mentioned before about the new consensus statement regarding the Indigenous population and the recommendations about commencing at 13 years, and that because of their high rates of comorbidities such as kidney disease, is that they start screening at age 18 and CVD risk be calculated from 30. And that should be taken in Indigenous populations as a minimum risk. There's a lot of heterogeneity in Indigenous populations around Australia. So if you work in an area and it shows that they are at moderate risk and they are Indigenous person, you can assume they are actually at high risk. Okay, I'll hand it back.
Okay, thank you so much, Mark, for this this great presentation. And now there's, I guess, there's some time for a Q&A. Let me start with asking you, how do you deal with patients already on treatment for blood pressure and lipids as a primary prevention when calculating the absolute risk, absolute CV risk?
A good question, Nadev. Firstly, is that the risk algorithm is based on an untreated population. So if you simply enter in the data you have while they're on treatment, you'll systematically underestimate risk. So you can consider it a minimum risk. If it's possible, you may want to look at pre-treatment levels. If they were recent, if they only started on blood pressure recently, you could look at their pre-treatment levels and calculate from that and assume that other than the age, nothing much has changed. That will give you a more reliable. The better thing to do, I think, is to look, if they are low risk, is try taking them off the medication and then calculating their risk off medication. You mentioned that I headed the blood pressure, is that I reckon about a third of the people I see were young people with mild elevated blood pressure who are on medication. You stop it, their blood pressure went up by about 4 millimeters of mercury and their absolute risk didn't change at all. So, you know, the possibility is that you can identify and stop people who are taking it unnecessarily.
Thank you. And I guess treated blood pressure and cholesterol should be to the target. I've got another question, actually. It's about the absolute cardiovascular risk calculator. We know that it's a population-based model. What's your advice on individualizing risk prediction?
In brief, resist the temptation. And we always treat our patients as being exceptional, but really the risk algorithm, for most times, it's a utilitarian approach. It'll do the most good for the most number. There can be some misclassification if you do that as well, because people will tend to underestimate risk when it comes to absolute risk approaches. And so you're probably going to untreat people. You'll say somebody who's high risk is I know them better than the algorithm and therefore they're at low risk. It just isn't true.
Okay. I'll jump in here as well, because I guess one of those questions is I'll get asked a lot about the role of aspirin and role of antiplatelets in cardiovascular risk prevention as well.
Yeah, so traditionally, aspirin was recommended for high-risk individuals in primary prevention, but as you may know, I was involved with a SPRE, which was conducted in Australian general practice. So a SPRE, ASCEND and ARRIVE, three big primary prevention studies on aspirin showed no benefit, and especially in our group, in the elderly, it showed harm. So really now I think the days of aspirin being used for primary prevention is gone. The drugs that are recommended are the disease-modifying drugs of blood pressure and lipid-lowering drugs, and not antiplatelet agents.
Thank you. And one more question is, it's about the scan, cardio imaging techniques in like coronary artery calcium scoring. Where does this fit into routine cardiovascular risk assessment?
So I think coronary calcium scoring correlates well with an absolute risk score. So if you think about it, if you can do something in your own clinic without having to refer them off, expose them to radiation, etc., then that's the thing to do. I think, as I mentioned before, it does have a role if you have an intermediate or moderate risk individual who you have concerns about, then that may inform you about whether you'd reclassify them to a higher risk and therefore to treat them. I understand from Natalie that the Heart Foundation actually have a position paper coming out later on in the year, and as the year has not much longer to go, that can't be too far away. So I'd urge you to have a look at that when it does come out.
Okay, thank you. That was great, and that will take us to the end of the Q&A. I'll just hand over to Natalie.
Thank you so much, and thank you again, Mark, for that incredibly engaging presentation, and thank you, Atta, for your wonderful co-facilitation today. I'd like to leave this session with a few key takeaways, and hopefully I do justice to what Mark has so eloquently described, and that is really that the absolute risk approach is more effective in preventing coronary heart disease events compared to single individual risk factor approach. I think we've learned that perhaps risk assessment in primary care is still suboptimal, and we can do a lot more to actively screen and treat patients at high risk in Australia. Mark provided a great description of how the heart health check can be used by practices, by yourselves, by your practice nurses, and even your practice managers to support systematic screening in high-risk individuals. And perhaps, especially in that Q&A session at the end, we learned that there's still quite a bit that we don't know about risk prediction, and in the future, potentially risk prediction techniques, things like cardiac imaging or novel biomarkers may be integrated into these risk assessment models more readily. I want to draw your attention now to the Heart Health Check Toolkit, which the Heart Foundation will be launching very soon. It will essentially be a one-stop shop of all of the tools and resources that you and your practice staff and colleagues will need to implement the Heart Health Check in the most convenient way possible. And I think, Mark spoke to assessment plans and management plans, and just like you have access to templates around chronic disease management, this toolkit will provide you with assessment and management plans for the heart health check, and will really help you to most conveniently use the 20 minutes of the heart health check, and also help upskill your staff in really actively recalling patients via your practice software. So please visit the Heart Foundation website via that link there below, and do register your interest to be one of the first to receive that. We've also got a really engaging webinar series. Mark, you're on there again, but we've had a few, and perhaps our latest one is of interest on the future of cardiovascular disease risk assessment and the evidence, the latest evidence update in that. So I encourage you to visit our website to get some more information. And, there is a huge amount, including things for your patients, communication tools like the Heart Edge calculator or our animation on the heart health check, as well as lots of information for you and your practice staff. So please do visit our website if you have any further needs. I want to thank once again, Professor Mark Nelson and Dr. Atifa Ashton for their time today and facilitation and presentation. Please do not hesitate to contact me directly with any questions, and I will redirect these questions to our speakers if they're relevant. And please do come visit our virtual exhibition space where the Heart Foundation will have lots more resources and will be able to answer your questions. Thank you.